Hello, my name is Guillaume Turc. I am a professor of neurology at the University of Paris, France, and I co-chaired the ESO-ESMINT expedited recommendation on intravenous thrombolysis before mechanical thrombectomy with Professor Jens Fiehler.
Yes, hello. My name is Jens Fiehler. I'm from the Department of Neuroradiology at the Hamburg University Hospital Eppendorf, and I'm the partner of Guillaume in this guideline on behalf of ESMINT, the European Society of Minimally Invasive Neurological Therapy. This guideline was really necessary because we needed to come up with a recommendation on the usage of intravenous thrombolytic treatment combined with endovascular thrombectomy. And intravenous thrombolytic treatment is the cornerstone of acute stroke therapy for many years. And based on this therapy, the entire acute stroke infrastructure was organized. And then in 2015, we had the very successful thrombectomy trials focused on stroke patients with proximal artery occlusions. And then the questions emerged for those patients, do we actually need additional IVTPA? And there were some pros and some cons. So the pros would be IVTPA might increase early reperfusion, might increase the rate of final reperfusion rate, shorten the procedure time, improve microcirculation. And the cons were that maybe IVTPA could increase the hemorrhage risk, delay the thrombectomy because of the additional processes, and thrombus migration might be enhanced, and clot disintegration and higher cost, of course, as well. So after all, there was only one way to answer these questions with randomized controlled trials. And these trials were conducted in the last few years, and we have now the results of those trials. And this put us into a position to write a recommendation that is very much evidence-based. And we had to do it in a very standardized and very controlled way.
Yes, we followed the European Stroke Organization standard operating procedure for developing guidelines, which is based on the GRADE methodology. And therefore, we formulated two PICO questions. PICO stands for population, intervention, comparison, and outcome. And we conducted systematic reviews and meta-analysis for the two PICO questions which we had identified. The first one was for Mothership patients, that is, patients who are directly admitted to a thrombectomy-capable center. And the second PICO question was for drip and ship patients, which corresponds to patients admitted to a center with the capability to administer intravenous thrombolysis, but not mechanical thrombectomy. Then we assessed the quality of evidence, and we formulated evidence-based recommendations. The GRADE approach allows us to completely distinguish the quality of evidence on one hand and the strength of the recommendation on the other hand. Whenever we felt that we do not have enough evidence to provide some evidence-based recommendations based on the GRADE system, we provided some expert consensus statements with secret ballot voting, and we used also the Delphi method. The aim of this strategy was to come up to clinically meaningful guidance, but those should not be mistaken as evidence-based recommendations. So one key methodological aspect for this guideline was the definition of the non-inferiority threshold, because the aim of almost all studies was not to demonstrate superiority of direct thrombectomy over bridging therapy. It was to show that it's still quite as effective if we withhold intravenous thrombolysis before mechanical thrombectomy. And therefore, this is really a matter of definition of a non-inferiority margin. So in order to predefine our non-inferiority margin, we conducted a secret ballot voting among the 18 members of the module working group, and values proposed by module working group members for the non-inferiority margin range from 1% to a maximum of 5% for one member. And a majority of the module working group members voted for a margin of 1.3%, which is based on the results of a survey of US stroke neurologists who tried to define the minimal clinically important difference for a new treatment.
Finally, we were in the position to have access to the outcome of 6 randomized controlled trials, direct MT, DEVT, Mr. Clean, no IV, Swift Direct, Direct Safe, and SKIP. SKIP is a Japanese study with a slightly different dosing scheme for IVTPA. And we did a very detailed meta-analysis of those trials. And they were slightly heterogeneous in their outcome, but overall, the result was pretty clear that the point estimate was minus 1.9% in favor of IVT plus thrombectomy. And the lower margin of the 95% confidence interval was minus 5.9%, which was below 1.3%. And it was also below 5% as our minimally clinically important difference. So there was no doubt in the end whatsoever that we have to stay with IVTPA in combination with thrombectomy for the Mothership patients. And the recommendation says exactly this thing, that for patients directly admitted to a thrombectomy-capable center for an ischemic stroke within 4.5 hours of symptom onset with anterior circulation, large vessel occlusion, and who are eligible for both treatments, we recommend intravenous thrombolysis plus mechanical thrombectomy over mechanical thrombectomy alone. Both treatments should be performed as early as possible after hospital arrival. Mechanical thrombectomy should not prevent the initiation of IV thrombolysis, and IV thrombolysis should not delay mechanical thrombectomy. The quality of evidence was graded to be moderate, but the strength of recommendation to be strong.
So first of all, as you are aware, there's no randomized controlled trial of direct thrombectomy versus bridging therapy in drip and chip patients. So we had to rely on a systematic review of observational studies comparing direct thrombectomy and bridging therapy in drip and chip patients. And unfortunately, the literature on this topic is scarce. Still, in our meta-analysis, direct thrombectomy was inversely associated with a good functional outcome at 3 months with an odds ratio of 0.63. This was significant. And the probability of reduced disability over the whole range of the MRS was could only be assessed in one observational study, suggesting also a significant inverse association. But our recommendation was not only based on the results of this systematic review and meta-analysis. We also considered that even in the Mothership setting, which is much more favorable to direct thrombectomy than the drip and chip paradigm, non-inferiority of direct thrombectomy could not be demonstrated at this point. So it would not really make sense to withhold IVT in drip and chip patients, especially because this might also result in denial of any reperfusion therapies in some patients who will reach the comprehensive stroke center outside the time window for mechanical thrombectomy, and also in those patients with unsuccessful thrombectomy. And therefore, we provide a similar recommendation for the drip and chip patients as for the Mothership patients, which read as follows: for patients admitted to a non-thrombectomy capable center for an acute ischemic stroke of less than 4.5 hours duration, with anterior circulation large vessel occlusion, and who are eligible for both treatments, we recommend intravenous thrombolysis, followed by rapid transfer to a center with thrombectomy facilities. Importantly, intravenous thrombolysis should not delay the transfer to such a comprehensive stroke center. However, the quality of evidence was judged to be low, but still we felt that this should be a strong recommendation.
So we have no information on the patients in the posterior circulation, so we cannot make recommendations on that. So trials in the posterior circulation would be interesting, but it's a difficult field to run studies in. But we will see what's coming out there, and there will be recommendations in the future on that as well.
So we are really looking forward to seeing the results of the individual participant data meta-analysis of the 6 randomized control trials. And we hope that this will give us more insight and might lead to a more personalized therapeutic strategies. It is possible that such an individual participant data meta-analysis disclose a differential treatment effect, for example, according to the site of arterial occlusion, or also depending on the key time metrics, such as the door to intravenous thrombolysis or the door to mechanical thrombectomy, groin puncture times. So we might have to update the recommendations based on some new findings. Another promising approach would be tenecteplase, which is a newer thrombolytic agent. And in the extended IA TNK trial, tenecteplase was suggested to be superior to alteplase with regard to early reperfusion before thrombectomy, and also with regards to 3 months functional outcome after mechanical thrombectomy. So other trials are planned or ongoing that will compare a direct thrombectomy with bridging therapy with tenecteplase, and we are looking forward to those results.
And another point that was incompletely addressed is the question of treatment beyond 4 and 5 hours after symptom onset, because there are also some data on the usage of IV TPA in this group of patients, but we didn't have sufficient evidence to make recommendations for this group. So this is also where further data is expected and will lead to more detailed recommendations.